This is a rare case of hemophagocytic lymphohistiocytosis, secondary to disseminated mycobacterium tuberculosis, supervised by Dr. Umber Najib. A 70-year-old female with hypertension and diabetes originally from the Philippines came to hospital with worsening confusion. She had no history of tuberculosis, and her examination revealed splenomegaly. Investigation showed bicytopenia with positive hemolytic markers and a DAT positive for IgG, concerning for warm autoimmune hemolytic anemia. Her ferritin was elevated at over 9,000, and a bone marrow aspirate showed hypercellularity with few hemophagocytic macrophages, not consistent with HLH. Extensive workup for causes of her presentation was negative. She was initiated on prednisone, but despite initial improvement in hemolytic markers, her counts continued to decline as she became transfusion dependent. Her ferritin peaked at over 14,000. She further deteriorated and developed worsening multi-organ dysfunction and underwent a repeat bone marrow aspirate and biopsy on day 15 of admission. Preliminary results showed focal granulomas negative for AFB and GMS, but this couldn't exclude an infectious process. An increase in hemophagocytic macrophages is seen on the right. She was empirically treated for presumed idiopathic HLH with IV etoposide, but was ultimately transferred to the ICU with multi-organ failure, where she later died. Posthumously, soluble CD25 was elevated, and bone marrow culture results returned positive for Mycobacterium tuberculosis. Ultimately, a diagnosis of HLH secondary to TB was confirmed. HLH is a rare immune-mediated condition, and patients can present with fever, hyperperitonemia, and cytopenias that can rapidly progress to fatal multi-organ failure. Diagnosing HLH is challenging as it overlaps with several systemic conditions. Treatment involves immunomodulatory agents, however, mortality rates remain high despite aggressive management. Thus, early recognition and identification of triggers is key. HLH can be primary or secondary to malignancies, autoimmune conditions, infections, or other causes. Bacterial infection is a trigger in 9% of adult cases of HLH, of which 38% can be due to tuberculosis. In a review of TB-associated HLH cases, a diagnosis of TB was based on histopathology in 100% of cases, 50% had positive cultures, and notably only 16.7% had clinical or radiologic findings consistent with TB. TB-associated HLH is a highly fatal condition, but in one review of 35 cases, 60 to 78% of patients survived after receiving anti-TB treatment with or without immunomodulatory agents, while all those who were not treated with any anti-tuberculosis therapy died. Bacterial infections are thus important to identify as they alter management, and current consensus recommendations state that HLH induced by intracellular infections requires treatment with pathogen-specific therapy. Overall, in presenting this case, we hope to emphasize several key learning points. HLH is a challenging disease to diagnose as it can mimic several conditions. Bacterial infections such as tuberculosis are key HLH triggers, and treatment with pathogen-specific therapy can save lives. Timely treatment initiation to improve patient survival requires increased awareness and early recognition of HLH and its triggers. Thank you.